Mandibular number 36, number 46, simple case. Annam with Dental Clinic. Directors Dr. Seung Im and Dr. Seung Kim. This is a female patient in her 50s. Both her first molars in the mandible were extracted a few years ago. Since a certain period of time has passed since the extraction, the adjacent tooth is exhibiting a slight mesial tilt. There is minimal loss of bone height and width, however. The amount of attached gingiva initially appeared to be sufficient. By looking while moving the mirror, however, the attached gingiva was found to be inadequate. The mucogingiva is formed like this. Flapless surgery seems to be an option, but performing flapless surgery under this condition is actually impossible. The incision must also be made slightly toward the lingual side from the middle crest. Afterward, I will make a circular incision on the mesial side of the adjacent teeth. The crestal incision will be made slightly toward the lingual side in the middle. The crestal incision on this region is very important. The incision will be made slightly toward the lingual side to secure at least 2 millimeters of attached gingiva on the buccal side from the mucogingival junction. Flap reflection is being done with a periosteel elevator. Hold the buccal side with a vestibule together and suture. The suturing silk has to go from the buccal side to the lingual side after moving from the lingual side to the buccal side to prevent the silk from getting entangled. As you can see, the ridge width and crest width are sufficient for implant installation. When the second molar is tilted toward the mesial side, the implant can be installed in the exact position by using a stent. Without a stent, however, the implant is generally installed slightly closer to the second molar. That is because you tend to look at this line. And if you see this superficial area, the center seems to be this region. The implant must be installed in the actual center between this end and that end. As such, when there is angulation, the fixture is tilted toward the distal side in many cases. Thus, the center of this line and this line must be determined. It is usually decided at this point. This is a kind of an optical illusion. The center should be somewhere here. The buccal lingual direction and mesial distal direction must be verified by inserting a parallel pin. Check the direction by asking the patient to close her mouth gently. It is okay if the parallel pin points to the personal functional cuspid of the opposing tooth when the mouth is closed. Checking the mouth opening pattern of the patient before the surgery is also recommended. This is because there are cases wherein the patient senses the parallel pin. As such, she cannot chew normally. I think this direction is the habitual chewing pattern. It is nearly within the functional cuspid. The buccal lingual path is good. Next, check the mesial distal path. Of course, simply checking with the naked eye is easy. Note, however, that the most exact method is securing a periapical view, if possible, prior to surgery. At this point, the rest will be uneventful. Let's see if we have reached 11.5 millimeters. It is better to check, since the depth gauge can go farther than the actual drilling if there is a perforation on the lingual side. Drilling has to be done only on the whole area. A drill with diameter of 4.1 millimeters shall be used as the final drill. A GS2 implant with diameter of 4.5 millimeters and 10 millimeter fixture will be installed. This installation depth is just right. Installing the GS fixture about 0.5 millimeters subcrestally is recommended. You can easily remove the fixture mount by turning it like this. If the fixture fixation is not good and is performed at less than 20 Newton-centimeters torque, the fixture may move around with the mount during the removal of the fixture mount. Let's now connect the healing abutment. There are two types of healing abutments, 553 and 555. You can select according to the surrounding soft tissue. It is better to use a healing abutment that is not too tall. Many problems can arise from using a tall healing abutment. One of these is the patient chewing the healing abutment. This can cause the healing abutment to loosen and deform. Thus, choosing one that is equal to the gingival height is recommended. At this gingival height, we can use a 553 or shorter healing abutment. Note that the gingival and healing abutment levels are almost equal, and this height is appropriate. If a healing abutment about 2 millimeters to 3 millimeters taller than the gingival height is used, a situation similar to the one I mentioned earlier may occur. Thus, I prefer using a healing abutment that is not too tall. Using a healing abutment that is considerably shorter than the gingival height may also cause problems, however. Thus, selecting a healing abutment that is slightly taller than or equal to the gingival height is strongly recommended. Let's now do the suturing. The mucogingival junction is approximately here. The amount of attached gingiva has more margins. We can try flapless surgery under these conditions, but the gingiva on the buccal side is insufficient. Thus, we shall go with the conventional method. The hard tissue condition is fairly good. If the attached gingival line had passed about here, I would have gone for flapless surgery without any second thought. As you can see here, however, the mucogingival junction is at this position, leaving a hole formed on this area had flapless surgery been done. When a hole is formed, the buccal has no attached gingival. Thus, for better results, the incision must be made slightly lingually and then sutured. I will change the incision design slightly at this time. I will leave the papilla on the left and right and make a small vertical incision. In this case, no grafting will be done, so I will not go over the mucogingival junction. Just proceed slightly further and leave the papilla, and then make a vertical incision. Make a vertical incision here in the same manner. For incision design of a single missing, performing circular incision is more convenient when suturing. If there is a recently placed prosthesis near this area, and you do not want to change the margin, however, circular incision and suturing performed on this area will cause slight resorption. A different incision design may be considered in this case. The crestal decision is important. The mucogingival junction is here. Thus, to leave at least 2 millimeters of attached gingiva on the buccal side, crestal incision must be done carefully. If you think it is to be split in half like this, the tissue from here will be moved to the buccal side. Thus, the attached gingiva from here to here can be secured on the buccal side. The flap does not have to be reattached beyond the mucogingival junction. The degree of retraction is sufficient. The floor must be felt at 11.5 millimeters when the depth gauge is inserted into the hole. If the drill is inserted deeper than the selected drill length, the lingual side may be perforated. Drilling should be done on the stopper area. The depth control of SS can be done exactly by installing the fixture on the border of the surface treated and untreated area. Since the fixation is good, the fixture mount may be removed without using an open wrench. As I mentioned earlier, you can easily see that an incision of this design may pose difficulties during suturing. The circular incision needs only about 2 interrupted sutures, whereas an incision line left around the healing abutment may be a disadvantage. Ideally, the healing process and pain relief should gain primary closure around the healing abutment if possible. These are the surgery results. A healing abutment was connected immediately after installing a GS2 implant on the mandibular left region. An SS2 implant with wide platform has been installed on the mandibular right region, considering the emergence profile. Since there were no difficulties in fixture fixation, impression taking will be done after 2 weeks. You probably think that this surgery is a very simple case. Note, however, that the incision design for the flap must be determined based on the mucogingival junction to secure sufficient attached gingiva at the buccal side. Hello everyone, I am Dr. Kim Se-ung, and I shall proceed with the prosthetic procedures following the implant surgery done by Dr. Im Se-ung. This is the condition of the patient during the initial diagnosis. Implants are installed on both first molars in the mandible. A SS2 diameter 4.8 by 6.0 wide platform 6.0 implant is installed at number 46 based on various surgical diagnostic procedures. A GS2 implant with diameter of 4.5 millimeters is installed on the mandibular left area. There are many advantages in selecting a SS2 diameter 4.8 by 6.0 wide platform for the first and second molar region for a better emergence profile. A fixture with diameter of less than 4.0 millimeters for the posterior region is not a correct selection in the case of a GS2 implant. A fixture of the internal connection type is structurally weak. Thus, select one with diameter of more than 4.5 millimeters and one with diameter of more than 5.0 millimeters, if possible, to secure structural stability for the prosthesis. There are many ways of taking an impression. In fact, various methods are available, including fixture level and abutment level. When the case is clinically simple, selecting the abutment level over the fixture level is more convenient and advantageous. Thus, I decided to go with the abutment level for this patient. Note that I did this after removing the healing abutment. We are now connecting the abutment. A rigid abutment is being attached for the GS2 implant. An abutment level impression is taken for a GS rigid abutment or an SS excellent solid abutment. Both are of the cement retained type. 3 decisions must be made when connecting a rigid abutment. First, since the implant is of bone level, the collar height must be determined according to the implant depth. Second, the collar diameter must be decided based on the tooth position. Finally, the height must be decided according to the vertical space. In this case, it is a first molar. Thus, the collar height was set to 2 millimeters, considering the installation depth, collar diameter of 6.0 millimeters, and height of 4.0 millimeters. A 1.2 hex driver is used to connect a rigid abutment. Afterward, tighten to a final torque of 30 Newton centimeters using a torque wrench. Next, select an impression coping and take an impression. The impression copings for rigid abutments are made of plastic, like this. They are also color-coded according to height. For example, the impression coping for a height of 4 millimeters is yellow, that for a height of 5.5 millimeters gray, and that for a height of 7 millimeters blue. The diameter is differentiated as 4.0 millimeters, 4.5 millimeters, and 5.0 millimeters. A 4 millimeter excellent solid abutment has been connected. The impression cap is connected in the original position. Afterward, the positioning cylinder is attached in the correct position. Impression taking then follows. Impression taking will be done using rubber impression material. Remove the impression body once the impression material has set. The plastic component is attached to the impression body, like this, when the impression body is removed. A plastic protective cap is then attached to protect the abutment. Afterward, the analog is attached following the removal of the impression body. This is sent to the dental laboratory, and a model is fabricated with G-mask for the final prosthesis fabrication. This is the final prosthesis made through wax-up procedures. If you take a close look, the analog has been modified slightly. 4 millimeters was connected, but the vertical space was slightly insufficient for crown fabrication. After reducing the insufficient area, a reduction cap that will facilitate the reduction process intraorally was made. After connecting the cap, the convex redundant area was removed using a burr. This is how to do modifications using a reduction cap. Afterward, attach the final prosthesis inside the patient's mouth and check its margin. Occlusal adjustment is carried out after this process. Adjust the occlusion so that natural teeth have stronger contact. The intensity of the contact points and margin fitness must be verified before proceeding with the occlusal adjustments. The natural teeth must have a slightly stronger bite, although the implant must have a weaker bite following occlusal adjustment. Of course, this does not mean that an infra-occlusion must be made. Adjusting the occlusion is very important to give a relatively weak bite on the implant even when it is not infraocclusion. Once the occlusal adjustment is finished, the prosthesis is high polished and prepared for setting. In applying cement, I do not apply on the entire margin. Instead, I limit the application to the occlusal surface to minimize the danger of residual cement. Ask the patient to close her mouth. If the height is appropriate, ask her to close her mouth firmly once more before the final finishing touches. This is the final prosthesis following the removal of the residual cement. In this case, the treatment for the mandibular left area was completed using a GS2 implant as well as cement-retained type prosthesis using a rigid abutment. On the other hand, treatment for the mandibular right area was completed with an SS2 wide platform implant and a cement-retained crown using an excellent solid abutment.